Now let's talk about another interesting topic, which is your headache. Class, headache is pain within the cranial vault. It is any pain within the cranial vault. Now, when I talk about headache, especially occasional ones, this usually leads to annoyance on the part of the patient, whereas your chronic headache may be debilitating on the part of our patient and also to the family. One concern that you have with your headache, especially if you're dealing with chronic ones, is the compromised ADL, activities of daily living, and also the decrease in the quality of life, or your QOL. That's why we need to address these patients. Now, the pathophysiology and manifestation. Okay, when we talk about headache or the source of pain, you might be wondering what part of the head is having pain or what part of the brain is having pain. Class, the pain-sensitive structures within our cranial vault are listed on this slide. One, your supporting structures that would include your skin, muscle, and your periosteum. So class, your periosteum is the border of your bones. Okay, it's the external covering of your bones. Then you have your nasal cavities and sinuses. Then you also have portions of your meninges. Also your cranial nerve number 2 to 6, 9, and 10. Then you have your cerebral vessels, okay, which would include even your facial and your scalp structures. Now, class, these areas of the body are capable of pain perception, meaning any inflammation, any irritation on this part of the body would lead to pain as an experience of your patient. Now, let's talk about the pathophysiology. So your pain experience is because of any of these four. It could be stretching or traction of the previous parts that we have mentioned. It could also be because of inflammation due to an underlying infectious process. It could be because of pressure, also because of enlargement of one part of the body or one part of those structures, and then also your compression and dilation. Okay, any of these factors could possibly lead to headache. Now look at that. Dilation leads to headache. Hence, an increase in ICP would also be manifesting as headache. Now, what are the types of headache? When I talk about primary headache, there is no organic cause, but it could be a result of a complex interplay of your muscles, nerve, blood vessels, and pain-producing substances. Whereas, when I talk about migraine headache, so class, your migraine headache is the most common type among your vascular headaches. So it's familial and it is more common among female compared to your males. Okay, it's the most common type of vascular headache. Now, your migraine headaches are triggered by hormonal changes. Okay, so serotonin is a chemical necessary for communication between the nerve cells. Recall our discussion that serotonin is considered to be a neurotransmitter. Our serotonin class could cause narrowing of your blood vessels throughout the body, referred to as vasoconstriction. Now, when serotonin or estrogen levels would change, the result of it would result to migraine. Okay? Now, if you would look at it here, once there is increase in serotonin class, that would lead to vasoconstriction. And because of vasoconstriction, there will be reduced cerebral blood flow. And because of the reduced cerebral blood flow, your autoregulatory mechanism would try to activate. Okay, your autoregulatory system will try to increase the blood pressure. And then to increase the blood flow, I mean going towards the brain or going towards the cranial area. Now, that would lead to vasodilation and later on neurogenic inflammation. And then later on, that would lead to decrease of serotonin, okay, which in turn would lead to. Now, here are other triggers of your migraine. Okay, you have your bright lights class, stress, depression, sleep deprivation, fatigue, odors, food that would contain tyramine, and use of your oral contraceptives. Other than that, the hormonal changes during menstruation could also trigger your migraine attack. Now, there are several types of migraine headache. One, you have your classic migraine with aura, and then you also have your classic migraine without aura. Now, when I say aura class, your aura is it's a focal neurological symptom. Okay, your aura is a premonitory sign. Okay, it's like a warning sign. Now, let's look into the stages of your classic migraine with aura. You have your prodrome, that's because of this before the illness state. Then you have your aura stage. So during your aura stage, you will have your focal neurologic symptoms. That would include visual disturbances, which could either be bright spots or flashing lights, zigzagging across the visual field, okay, which would last from 5 to 60 minutes. Other symptoms, then you have your numbness, tingling on the lips, face, or hands. Then you also have mild confusion, slight weakness of the extremity, drowsiness, and dizziness. Now, class, if your patient have been a migraine head patient for long, okay, they will be able to recognize that this is the aura that they have. In other words, this is the warning sign that they would usually experience, class, prior their episode. So once they know, class, that they have the aura already, okay, they will be prompting themselves to stand by, to calm down in such a way that if ever they will have a migraine attack, they will be prepared. Okay, now you have your headache stage. So in your headache stage, class, that is where the throbbing headache would occur. And take note that the throbbing headache is usually unilateral. Okay, unilateral throbbing headache. We're in, class. Okay, we're in vasodilation. Okay, severe incapacitating photophobia, and the nausea and vomiting may be occurring. And this usually happen from a duration of 4 hours to 3 days. Okay? Now, look at that. There's a post-headache stage. In the post-headache stage, recovery on postdrome, okay, also referred to as recovery or postdrome, muscle ache and localized tenderness would occur. Okay, muscle ache and localized tenderness would occur. Now, exhaustion and mood changes will be evident. Then the tendency of the patient is to sleep because the patient would appear tired, okay, because of the too long headache stage. Okay, so because of the too long headache stage. So again, okay, your stages of classic migraine with aura would include the prodrome, the aura stage, the headache stage, and then the post-headache stage. Now let's proceed to migraine headache without aura. Now, since the term implies that there is no aura, class, okay, obviously for this kind of migraine, there is no premonitory signs or there is no warning sign that the migraine would occur. So this type of migraine is usually associated with hereditary factors. And the headache could last from hours to days, and they occur during period of premenstrual tension and fluid retention. Okay, that may be related to the hormonal changes that occurs in the body of women. Then you have your chills, nausea, and vomiting, then fatigue and nasal congestion. Okay, so as the term implies, migraine without aura headache. So commonly related to heredity. Now, the next type of headache that you have is your cluster headache. So class, it's referred to as cluster because, quote unquote, it is clustered in quick succession. Now, so this is a vascular headache predominantly, and it is experienced by men aged 20 to 40. The triggers of your cluster headache are usually your alcohol and nitrates. Okay, so you have your alcohol and nitrates as the trigger of this type of headache. Now, the manifestations is that it's negative on prodromal signs. However, class, it has intense unilateral pain around or behind one eye, which awakens the client. Okay, so again, the pain would be behind one eye, which would awaken the client. So class, the pain would begin in the infraorbital region, going towards the head and the neck. And then it is considered to be one-sided. Okay, look at this image. This illustrates that the pain is behind the eye and then surrounding the eye, and that it would go towards your neck. Now, the pain would occur with rhinorrhea, and then you have lacrimation, flashing, sweating, facial edema, and possible meiosis or ptosis on the affected side. So, class, when I say meiosis, this is related to your pupillary constriction. Okay, then you have your ptosis or the drooling of your eyelids. The duration, class, could be 15 to 30 minutes to a few hours, and it would be abate abruptly. Okay, so meaning the occurrence and the way it stopped is abrupt. Now, your cluster headache again would be manifested by watery eyes, drooping eyelid, and runny nose. So hence this illustration. Okay, as you can see, this is ptosis, class. Okay, you can also witness that there is meiosis. Okay, meiosis, which is the constriction of your pupils. Then watery eye or lacrimation that we talked about earlier, and then your rhinorrhea or fluid through your nose. Furthermore, the next type of headache is referred to as your tension headache. So class, your tension headache is a headache related to muscle contractions. Okay, it is an ill-defined bilateral headache, which is vice-like. Okay, so class, when I say vice-like, it is extremely tight and firm. Now, the possible areas of pain could be the upper back and neck. It could be the base of the head. It is also on the ears, above the ears, the jaw, and even above the eyes. Now, so these are different types of your headache. So you have your sinus, cluster, tension, and then migraine headache. Okay, so this is how internet resources would be able to differentiate these four. Then you have another. Okay, so class
Other than those types of headache that we talk about, so recall that I've mentioned about migraine, you have cluster and then tension headache. Another way to categorize your headache is by saying whether the headache is vascular or non-vascular. So class, your vascular headaches are your migraine and cluster headaches, and then your non-vascular headaches are your tension headaches. So recall class that your tension headache are usually related to the tightness of the muscles. Now, you have your secondary headache. Earlier, when I talked about primary headache, there's no known cause. But here comes secondary headache. Class, since it is secondary, your secondary headache may be secondary to any of the following conditions. One, you have your subarachnoid hemorrhage. You also have your stroke, your severe hypertension, your meningitis, and then your head injury. Any of these conditions could possibly cause your secondary headache. So what is our care and management for those patients with headache? Comfortable environment would be one. Okay, chocolates, nuts, cheese, pork, then coffee, dairy products, and wine are not recommended for this patient because it would aggravate their headache. Added to that, for your tension type headache, we have your behavioral therapy. The behavioral therapy is intended to reduce the stress of your patient. So included in this now could be your psychotherapy and your biofeedback. We also give medications. Okay, we improve poor posture because your posture, as mentioned earlier, your tension type headache is related to muscular tightness. So your poor posture may lead to muscular tightness, muscular problems leading towards your tension headache. So for that reason, your posture is an important part of management. Then comfort measures. So class comfort measures would include performing gentle massage to this patient. Or the laboratory and diagnostic test. Recall class that there are several reasons for the headache. Okay, we are even considering subarachnoid hemorrhage as a reason for headache. Hence class, if your patient headache is unresolved for how many days, 2 months, and there are accompanying signs and symptoms, you need to check for the presence of other comorbidities, which may be hemorrhage, which may be stroke for that matter. For that reason, class, we are doing your brain scan. We're also doing your MRI. The X-ray of the skull and the spine is used, class, to rule out for fracture and other gross injuries. For your spine, it is used to rule out also, class, the abnormality on the curvature of your spine. Your EEG, on the other hand, is used to evaluate for the electrical activity of your brain. Whereas your lumbar puncture with CSF analysis is done, class, to detect for the presence of infection. We also do your serometabolic screens and hypersensitivity testing. Your metabolic screens would be necessary, class, to rule out metabolic problems. And then hypersensitivity testing is necessary to evaluate for problems on allergic reactions. So by the way, your CSF analysis is usually done if inflammation is suspected, which implies that infection is more likely. For that reason, your lumbar puncture with CSF analysis is done. So class, we have the following medications. So you have your serotonin antagonist. Recall earlier that we have mentioned that the increase of serotonin could possibly lead to migraine headache. One of the factors or hormonal factors that we consider is the increase of your serotonin. For that reason, class, we have medications such as your serotonin antagonist. An example of which is your methylsergide maleate. Then another class is your beta blocker. Recall that your beta blocker is actually an antihypertensive medication. Class, your beta blocker such as your propranolol may be able to decrease the blood flow going towards the brain. Then you have your calcium channel blockers. Class, your calcium channel blocker, an example of which is verapamil. Then you have your tricyclic antidepressants such as your amitriptyline hydrochloride or Elavil. And then class, you have your ergotamine tartrate. A common brand name for which is Cafergot. Now class, your ergotamine tartrate would help narrow the widened blood vessels in the head. Again, class, ergotamine titrate would help narrow the widened blood vessels in the head, which later on would reduce the throbbing effect or the throbbing effect of vascular headache. Now, you also have your triptans. Class, your triptans, an example of which is sumatriptan, then you have rizatriptan, and then you have naratriptan. Your triptans are considered to be SSRAs. For sumatriptan, the common brand for that is Imitrex. Class, in fact, these are the drug of choice for your migraine headache. Class, your sumatriptan is considered to be a vasoconstrictor. It's a vasoconstrictor. Specifically, we're talking here about cerebral vasoconstriction. And the aim of which is to limit dilation, which aims to decrease the blood going towards your head. In such a way that would not be increasing your ICP and then result to headache. However, please take note that your sumatriptan is highly contraindicated for a patient with hypertension, then renal and hepatic impairment. Now, once your patient is experiencing severe pain and could not be resolved by these medications class, okay, you can administer already your narcotic analgesics. A good example of your narcotic analgesic will be your meperidine. Okay, your meperidine demerol. Okay, so that's one example of your narcotic analgesic. Then you also have your antiemetic drugs, because recall that in headache, nausea, and vomiting could possibly occur. So once the patient is still nauseated, okay, is just nauseated class, you may give already your antiemetic medication for you to prevent vomiting from occurring. Because once vomiting would be occurring, you will be considering again fluid volume deficit as another problem of your patient. Then, following the WHO ladder for the management of pain, you may have your narcotic, non-narcotic analgesics also. Then, here are the following nursing diagnoses that our patient may have. So your patient may be diagnosed with pain, or acute pain, or chronic pain for that matter, related to the inflammatory processes inside the cranial cavity. Then you have your ineffective individual coping related to the pain experienced by the patient. Okay, third class, you have sensory perceptual alterations because of the vertigo that the patient may be able to experience. Other than that, we also have your deficient knowledge. Okay, you also have your fear, sleep pattern disturbance, and altered role performance. Class, the last three from fear, sleep pattern disturbance, altered role performance, okay, these are all related to the direct pain experienced by the patient. Okay, direct pain which is experienced by your patient, leading towards sleep pattern disturbance and altered role performance. Now, just for you to remember the three types of headache that I've been talking about, so I have this table. So class, you have your migraine headache, you have your cluster headache, and your tension headache. The trigger class for your migraine headache, okay, is the stress and crisis. So when I say crisis, it is any new event in the life of an individual. Okay, so that's a crisis for an individual. So stress class or crisis may possibly need to use medications for you to manage the migraine headache. Now, this is usually related to the inflammation and the dilatation of the blood vessels. For that reason, if you can notice, we will be giving medications that would constrict the blood vessels. Other than that class, the signs and symptoms appear to be on the one side. It is also throbbing and pulsatile. And then other than that, there's nausea, vomiting, chills, fatigue, photophobia, and phonophobia. Then for the management, okay, environment. We want a less stimulating environment because we don't want for seizure that the environment is very conducive to enforce or to have abnormal electrical discharges. Now, you also give your medications. So class beta blocker, calcium channel blocker, you have your tricyclic antidepressants, you have your non-steroidal anti-inflammatory drugs, your ergot derivatives, and then you have your triptans. Triptans as the drug of choice for your management of migraine. Now, you have your alcohol and nitrates as the trigger for your cluster headache. So class, it is clustered in quick succession, meaning they would occur in clusters for this hour, then it will stop for a little while, okay, or for a long while, and then it would occur in clusters again. When I say clusters, class, it could be also a series of headache on a single day. Now, its characteristic is that it's intense, deep, and usually unilateral and would involve the eyes. Okay, notice that there is involvement of the infraorbital region to the head and neck. Okay, so class, usually the pain is felt behind the patient's eyes and then going towards the neck and then going towards your head. Now, flushing and nasal stiffness may be present for this patient. Whereas class, in your tension headache, okay, your tension headache is related to the tension and muscle contractions. Class, your tension headache, okay, is not usually unilateral, unlike your migraine and cluster headache. Your tension headache has a big tendency to be bilateral and would include even the neck and the shoulders. Okay, class, for your cluster headache, the drug of choice will be your narcotic analgesics. Whereas for your tension headache, okay, you have your non-narcotic analgesics. Okay, so the use there of the non-narcotic analgesics class is related. Okay, it's related to the pain experience of your patient. Okay, I hope that if you would pause this slide, it would offer you some enlightenment as to the difference of these three types of headache. Now, the next topic that we'll be talking about is seizure. Thank you very much for listening to this one.